Good morning, good afternoon, or good evening, wherever you are in the world. Over the last year or two, we've been preparing a report for the ICRP on radiological protection aspects of imaging in radiotherapy. That's out for public consultation at the moment, so we're going to tell you this morning a bit about what we've done in the report, and then hopefully those who feel motivated can provide us with comments, which should be in before the end of May. So I'm going to talk about the images that are used in planning and verification. I'll talk about the different modalities that are available, the benefits and risks from imaging, say something about the frequency during radiotherapy treatments, and then talk about the optimization of imaging and also about recording patient doses for the main technique that's used, KV cone beam imaging. So conformal radiotherapy treatment fields are delivered from multiple directions so that the high dose can be focused on the tumor. So the machine continuously reshapes the beam. It changes the intensity as the gantry moves around the patient. So this enables the radiation field to be conformed more accurately to the shape of the tumor and allows doses to healthy tissue surrounding the tumor to be reduced. That's in theory. But these improvements in treatment can only be realized if the patient is positioned precisely in the location that's been planned. And in order to know this requires imaging. So imaging is used at various phases. It's used for planning the treatment. It's used for verification to adjust for any sort of positional uncertainty during treatment. And it may be used for assessing the response to treatment later on. Now, for planning, computed tomography is really the technique that's used almost universally. There are other techniques available, and these provide information on the organ function or physiology and anatomy. So positron emission tomography, magnetic resonance imaging, ultrasound, and single photon emission tomography can all contribute. But as far as imaging during treatment is concerned, KV imaging systems are the predominant one. So there's an X-ray tube and image detector plate frequently attached to the linear accelerator itself, and this can rotate around the patient and record planar or cone beam CT images. There's also the NV therapy source, which can be used with an electronic portal imaging device, but the images that are produced by this are much poorer and the doses are higher. So this is a KV system attached to a linear accelerator. That's the one that will be used. But imaging requires fields covering the area surrounding the tumor because you're trying to verify the exact position within the tissues. So this means that the normal tissues are irradiated, and there's an associated risk of second primary cancers. So I said the cone beam CT, which is an ionizing technique, is predominantly used, but there are non-ionizing ones. Magnetic resonance imaging is integrated into some linear accelerators, offering an alternative. And this is used in about 10 to 20% of radiotherapy centers in many countries. So there's a lot of variation in this around the world because it depends on the level of income. Optical surface guidance is based on projection of a light pattern onto the patient's skin, which is monitored using video cameras. And this allows assessment of the setup based on a large area of the patient's body. Ultrasound provides a real-time volumetric imaging, and it's got quite good soft tissue contrast, so it's used sometimes for pelvic and abdominal imaging. And non-ionizing techniques are used in about half of the radiotherapy centers for some treatments. Now, dose margins around tumor targets are used to account for uncertainty in delineation, anatomical changes, positioning, and movement. More frequent imaging allows these margins to be reduced to protect normal tissue. So image guidance may allow doses to tumor target to be raised if doses to critical organs at risk can be reduced. But the cumulative doses from imaging will, as I said before, contribute to the risk of second primary cancers. So there's a balance between reducing high dose margins around the target and lowering doses from imaging to surrounding normal tissues. So this imaging requires both justification and optimization. And Bill Small will be talking a bit later about this. So the options for optimization, there's the frequency of imaging, there's a volume of tissue around the tumor to be imaged, and there's also the level of image quality that you require in order to delineate the tumor. Now, surveys have shown that vendor protocols, those that are provided with the equipment, are frequently not optimized for radiological protection. They're optimized for imaging the tumor because that's the most important thing, but not necessarily for radiation protection. And 90% of radiotherapy centers use the vendor imaging protocols for cone beam CT in 2/3 of the countries who carried out the survey. So that's sort of based on the results that we got from that survey. So adjustments can be made to imaging parameters so that doses from imaging are reduced without necessarily reducing image quality. And fewer than 50% of radiotherapy centers in our survey made adjustments to protocols for individual patients. So we feel a lot of scope for optimization of radiological protection. But optimization of radiological protection requires a knowledge of patient imaging dose. If you don't know what the dose is, you can't assess the impact of any changes you make on reducing that dose. And 50% of European radiotherapy centers record patient imaging doses, but it's less than 10% of those in other parts of the world. So we needed a quantity that could be measured. There is a quantity displayed on some machines, but it's not universally used at the present time or displayed at the present time. And we needed something which could be measured. So we chose the cone beam dose index for use at the present time. And this is measured in the standard CT cylindrical phantoms with a 100 millimeter pencil ionization chamber. So use a wide beam covering the phantom and then rotate the beam to carry out a scan and record that dose. And this was first proposed by Ammer et al. In 2007. And Tim will be talking later about a UK survey using this technique. Now, we made various recommendations in our report, and I'll put a few of them now. There's the need for allocation of resources for image dose assessment and optimization. And optimization of image quality and dose should be part of the whole process of purchase, acceptance, commissioning, and quality assurance. But image optimization teams have been found to be quite useful or very useful in diagnostic radiology. So if you link together an oncologist, a technologist, and a medical physicist who focus on optimizing the imaging process, that can be a great help. And these teams can then review the imaging protocols in respect of image quality and dose at regular intervals. Another recommendation I'll mention is that we recommend that vendors should include displays of the measurable dose quantities. So there's a CTDI, which is quite complex to measure, but has been agreed by the International Electrotechnical Commission and it's linked. If we have a display of that linked to the exposure factors for imaging systems, then that could be used for patient dose surveys in the future. So, in summary, improvements in radiation treatment delivery require accurate patient positioning. Imaging is needed for both planning and verification. The radiation fields for imaging expose normal tissues surrounding the target. And so the dose from imaging needs to be justified and the techniques used optimized. KV cone beam CT is the main imaging technique used during treatment, and most centers frequently image at every fraction. So most centers use the protocols supplied by the vendors with limited optimization. So that's what we want to improve. But data is needed on the doses received by the patients from imaging to allow optimization to be carried out. So we'll be talking more about the different aspects of this. But I want to acknowledge the contributions from the members of the task group. And we've also had an enthusiastic group of mentees who've both helped us survey practices in countries around the world and also try out the feasibility of the techniques that we've recommended for dose measurement. So I want to hand over now to Jenia Vassileva, formerly of the IAEA, who will talk about the doses from imaging in radiation therapy.
Thank you, Colin. Hope you can see my slides on the screen. Can you confirm, please?
That's fine.
Yeah, thank you.
Yes.
Hello, everyone. I'll briefly summarize the information from the literature review on doses from imaging procedures in radiation therapy, and not only on during therapy, but also try to put in the perspective of the whole journey a cancer patient has with imaging. So imaging dose has been traditionally deemed insignificant as compared to therapeutic dose delivered to tumors and surrounding tissues. But changes in the patterns of imaging from 2D to 3D with more frequent exposures creates potential for more significant cumulative doses, as Colin just said, to large volumes of normal tissues surrounding the tumors, and this has become a cause for concern. We already heard from Colin and we know that imaging is used at every step of the journey of a cancer patient, from diagnostics and staging through planning and simulation during treatment and post-treatment for evaluation of results and follow-up. And all traditional diagnostic modalities are used, as well as such design for integration into the treatment machines that is, in fact, equipment in our focus today. The goal of dose assessment from imaging is to quantify the risk stochastic, either stochastic or deterministic for patients. But in fact, we know that this risk is unknowable because of many factors influencing. That's why you are using measurable modality-specific metrics from which we can then calculate other metrics such as organ tissue doses, or if needed, we can combine them as a risk index. The most used one is the effective dose currently. So for different modalities, we have different modality-specific metrics in imaging. They are based on air kerma measured in air, but then we can use either measurements in phantoms, but most often we use the Monte Carlo simulations and patients representing models to calculate organ doses, mean doses in exposed organs or tissues. The measurable quantities we use for quality assurance, for performance assessment, for dose audits, optimization, organ and doses and risk index, effective dose. we can use for comparing between different modalities and procedures. And we should always pay attention to the uncertainties because with the calculation step, especially for effective dose, the uncertainties is high. But it's very useful to compare exams like here. We know from various publications that typical effective doses from medical imaging procedures are in the low dose range. And risk is negligible to low, but if the patient accumulate more procedures, the effective doses and organ doses can go up to 100 and more, and the risk increases with this. And cancer patients need more diagnostic procedures prior and after treatment, and there are recent studies demonstrating that oncology patients need more, are among those who received more often above 100 millisieverts. And with the improved survival rates and improved life expectancy, this became a concern in regard to risk of second cancer, like in this example from Germany, showing that more imaging was used compared to the recommended by the lymphoma management guidelines, with in average 24 CT exams, exams with ionizing radiation, most of them CTs in the first year, and in the following years less, but still significant exposure. During the planning, we also need imaging, especially CT has important role. And here, doses are similar to the diagnostic exams with 10 to 100 milligray organs, but the CT used for radiotherapy planning has the specifics of using fixed tube KV, large bore CT, increased X-ray tube to detector distances, and this makes difference. And those audits and performed in UK, for example, showed large variations of the doses to patients from for the same protocols, but in different centers. And let's focus on the verification and use of imaging for verification and image guidelines, in which image volume is generally larger than the treatment volume, and tissues and organs outside the beam, therapeutic beam, are exposed to imaging radiation. So earlier reports for this used effective dose, but it was considered inappropriate because in order to compare doses with doses to organs adjusted to the treatment volume from radiotherapy, absorbed dose to tissues and organs considered to be the most appropriate. And these doses are reported either from measurements in phantoms or simulated with Monte Carlo methods and calculations. Dose distribution depends on the mode of image acquisition and the beam energy. In general, doses from 3D imaging are relatively uniform, while the 2D imaging, and especially KV imaging, because of the low energy, the maximum dose is located in the skin and superficial tissues and has a sleep decline with the depth by a factor of 10 to 100 to 2000. And here on the images, you see three different modalities used: 6 MV portal image, KV, cone beam CT in the middle, and on the right-hand side, or the planar KV imaging. MV, electronic portal imaging, according to the older data, delivers dose of around 150 to 100 milligray. And the more recent data demonstrate that these doses have declined with between 10 to 50 milligrays, depending on the study, depending on the treatment site. And those, of course, depending on the beam energy, 2.5 maybe MV beam delivers 50% dose compared to the 6 MV. The planar KV delivers substantially less dose than that from MV portal imaging, with studies demonstrating doses of order a few milligrays per image pair. And the specifics here is that dose done to bone is 2 to 4 times higher because of the prevalence of photoelectric effect here. And rapid dose drop is with the depth compared to the MV technique. Cone-beam CT, MV is used in some modalities, in some of the Linux. And according to the published data, you see here doses varying between 6 to 80 milligray, depending on the acquisition mode, depending on the monitoring units and the energy of the beam. And dose distribution resulting from this is not completely uniform, but better, more uniform compared to the portal imaging. And finally, KV, cone-beam CT, delivers lower doses compared to the MV technique, with large variations reported from 0.4 to 59, here is milligrays, and less dose, of course, in the newer systems due to improved hardware and software, but still large variations have been reported by a factor of 10 to 15 breast and 5 in prostate imaging in a Finnish study. And this dose is affected by various factors of the protocols. So cumulative doses are of concern, as it has been said. And from this study from Finland on the prostate cancer treatment, we learned that the cumulative doses from only the treatment phase can go up to 2 grays, 1-2 grays, depending on the number of fractions. And another study from China also demonstrated, and they already studied all different imaging modalities in a large cohort of patients, or also going up to in accumulation to specific organs of 2 and more grays. So in summary, doses to organs surrounding the tumor from a single imaging procedure during treatment vary from a few milligray for KV imaging to 30-50 milligray for MV imaging, but the repeated imaging can deliver from hundreds milligray to more than 2 grays to these organs, and imaging dose to tumor is generally less than 5% of the therapeutic target dose, except for some procedures that use MV beams, particularly cone-beam CT. The dose to surrounding tissues and organs at risk has to be considered independently, as imaging dose is not conformed to the target volume in the same way as the treatment. The organ dose from imaging can vary by a factor of 10 or more for the same treatment, depending on the chosen technique and imaging frequency. And particular attention is needed for children and small adults, because doses could be 2-3 times higher if exposure factors are not adjusted. And this combines with doses prior and after the treatment, increasing the risk of induction of further cancers. So awareness and optimization of the imaging dose in image guided radiotherapy should be strengthened. And this is the main focus of the report. Thank you for your attention.
Thank you, Jenia. So next we move on to our oncologist, Bill Small, who's also a member of ICRP Committee 3. And he's oncologist at Loyola University Medical Center in Chicago. And he'll try to explain to us something about the justification and optimization processes.
Thank you very much, Colin. I appreciate being on here. Hope you can see my screen. I'm going to talk a little bit about application of justification optimization principles in imaging and radiotherapy. I'm from Chicago, and I appreciate being able to talk to you. So disclosures are here. There's nothing relevant to this current presentation. The objectives for justification are some key points that we came up with: clinical benefits, considerations when making some decisions about image guidance, and specific sites and justification of image guidance. What I would say is I've been in practice for 30 years, and besides for computer improvements in our planning, image-guided radiation therapy has really made an incredibly big difference in how we treat patients. So the decision to, the decision to use additional radiographic imaging with increases a patient's radiation exposure must be justified by the anticipated clinical benefit. And what I would say, some of the discussions will talk about this. We don't have a lot of scientific data on what the right imaging is, and we really need to work on that. Key considerations include the imaging modality, the feasibility of visualizing the critical structures, anatomical structure, the ability to make necessary adjustments, the associated risk and potential benefits. It was touched on before, but adaptive radiotherapy is becoming more and more prominent, which means you're going to maybe even plan multiple times during the course of the treatment. It requires a large number of high-quality images to make and verify adaptations. Again, this will mean to be carefully weighed against the clinical justification of imaging protocol and practical considerations. The frequency of imaging may depend on the patient type, the treatment site, the disease entity, available resources, and the treatment protocol. Any deviation from a predefined imaging protocol for an individual patient should be clinically justified. Justification of the frequency of imaging for a type of treatment requires input from the radiation oncologist, the radiographers or radiation technologists, and medical physicists. And there are some recommendations from National Society and official bodies based on practice surveys offer specific guidance and general imaging strategies for particular clinical sites and scenarios with regular updates. So the clinical benefits, it really does improve the treatment accuracy, which enables often an increase in the tumor dose with a potential for better tumor control and survival. Irradiation of smaller volumes to reduce margins enables a potential reduction in complications. So image-guided radiation, the justification not only is for tumor control, but also for complication improvements. More accurate and potentially faster treatments can improve access to radiation therapy, similar to introducing a new indication for treatment. Enhanced accuracy and targeting may also enable new therapeutic applications. And the provision of data can be used to determine the appropriateness of delivering treatment. This becomes a consideration, for instance, when the patient anatomy has changed so much that the treating patient might now be inappropriate or otherwise have to be adapted. This is just some scenarios. It's one of the tables we use of why we would do imaging. Things like SBRT or SRS, which are very high doses to small areas. We always need to image and make sure we're targeting the right thing. High-risk treatment site, something near something that's very sensitive. I know that Tom Murch is going to talk about pediatric radiotherapy. Systemic difference between planning and treatment expected. We have a lot of patients that lose weight, the tumor shrinks. We need to make sure we're still hitting the target. Random variations like bladder filling makes the targets move, and significant interfraction motion, including breathing. So just really quickly touching on some tumor sites and what we do for brain, we typically set up to the frameless treatments with tight margins, which is attributed to IGRT. We typically locate the bone because there's not a lot of motion in the brain, but there is some. Head and neck, there's significant changes related to various factors, including weight loss and tumor regression, contribute to most head and neck radiation oncologists do daily volumetric imaging, in addition to margin reduction related to close organs at risk, which can reduce toxicity. Thorax is its own interesting target because the lesions move and adapting to the tumor reduction and the movement with breathing. The breast treatments often employ things like breath hold to limit the volume, but again, all this is dependent on image-guided radiation. GI, again, talking about nearby organs at risk and upper abdominal motion, and we talked a little bit about variations in bladder filling for GU and GYN. So the justification of imaging is very important, and it is something we use at a daily basis in clinical radiation oncology. So I talked a little bit about justification for optimization. I'll talk a little bit about the key points again, and then strategies for implementing optimization of imaging, professional collaboration, scientific expertise and methodology, and organizational processes and documentation. What I would say is if there's anything this document will do, it's make us hopefully make radiation oncology departments think more about this when they're treating their patients, especially as we get better at curing patients. I won't go into all these, but I think these are some of the key points. Radiotherapy staff should be aware of the volume of tissue imaging for planning and verification of radiotherapy. It's often considerably larger than the treatment volumes and may include critical structures. And I would say there's a culture of not really thinking about this, given as the other speakers have told, the dose is so much less than what we're giving. But opportunities for optimization of patient imaging should be considered when planning the acquisition of new imaging equipment. Optimization of exposure factors and volume of tissue to be imaged for a particular clinical task requires input from everyone. We need more medical physicists trained in radiology imaging skills related to patient dosimetry and optimization. If expertise is limited, we should seek assistance from our colleagues. Optimization teams for imaging should be set up to comprising of radiation oncologists, radiation therapists, medical physicists. Requirements for routine QC on imaging. Regulators and governments can encourage optimization through inclusion of requirements, and professional organizations play a role in developing and improvement in optimization. At least in the U.S., most of us have a accreditation from a society. I don't believe we've really talked much about that in the accreditation of optimization of imaging. I think that would get people to be thinking more about this. I'm going to just really quickly touch on these things. These are professional collaborations. Common starting points is we kind of work in isolation, meaning the radiation physicists don't necessarily always interact a lot with our imaging colleagues. And obviously the suggested goal is collaboration between imaging teams and clear links with imaging professionals with recognized roles. Scientific expertise, again, I'm not going to talk too much about this. This is in the report, but I think that a lot of us are still in the common starting point, which is we just accept and test and go with what the vendor does. Medical physicists in the department have some limited experience. We perform IGRT without imaging dose management, and then the suggested goal is to really do this as a best practice. And again, I'm not going to talk too much about this, just that the organization progress and documentation, I do think many of us still sit in the common starting point, but really we want to have multidisciplinary teams regularly reviewing this, establish expected doses, document it. I think the majority of us don't document the IGRT dose that we give to patients, which can be significant. So in conclusion, image-guided radiation has profoundly changed the field of radiation oncology with improvements in outcomes, both tumor control and toxicity. It has also expanded indications for therapy. So it is here to stay. It is something we use on a daily basis. Many times the dose from imaging is much lower than the treatment dose, and optimization imaging may not be given the attention it deserves in a radiation oncology department. And the use of optimization of image-guided radiation therapy should be prioritized, especially given improved outcomes of the treatments and often long life expectancy of the patients we treat. Thank you very much.
Thank you, Bill. We now move on to Tim Wood, who's going to tell something about his experiences in running a survey in the UK. So Tim's from Hull University, but he's been involved with IPEM in organising surveys of both planning and imaging during treatment. So I'll pass on to Tim.
Thanks, Colin. So I'm going to give this quick flavour of what's happened in the UK, a bit of a UK experience on looking at dose reference levels and audits of typical imaging doses in the radiotherapy environment. But just to give some context, I'll just giving a bit of a history of where I came from in that, I am a diagnostic physicist. And about 12, 13 years ago, we were getting queries from our colleagues. We sit on the same corridor, we're all very friendly with our radiotherapy physics colleagues. And we had a patient who was presenting that was very slim, very young. She's 27 years old, good prognosis. And they were imaging day after day, repeating imaging because they had setup issues. And they were just concerned about the level of dose because this felt like a lot of dose to this particular patient. Okay, and they were getting fantastic images. The images looked like this. It was an old ovarian type system. So what we did was over a course of a few fractions, and this is the great opportunity you have in radiotherapy because you see the same patient day after day. we turned it down a little bit. Okay, and by the end, we turned the dose down by a factor of 3, dose assessed by typical indices, CTDI type metrics. But significantly reduced the dose. The KD came down, the MA was reduced, the images were still fantastic, as you can see at the bottom, and they still fit the purpose. But we realized a very real dose saving for that patient. Around the same time, we also had those patients that were problematic. And this is one of the things that always bugged me a bit at that time, that there was this culture of, here's a default setting, you hit it, you use it day after day after day, you just keep hitting the button. But then we start to get, having done that other work, well, we've got this patient and it's not quite good enough. And this was a very large patient at 116 kilos. And so we went through the same process again, but also this time, the solution wasn't turning things down, it was turning things up. And remember, that's what optimization is about. We want an image that is suitable for the clinical task which you want to use it. So clearly this patient was suboptimal. It's quite hard to summarize in a single slice. The only option we had was to turn up the dose on this type of patient. Okay. But from this, we started to frame this idea, well, we have these slim patients, we don't need as much. We have these big patients where we need a bit more. And from that, we did a whole body of work and we came up with our own size-based modes. We deviated from that default setting for Valder. While we introduced selection criteria to allow us to sort of guide us where we wanted to go. But the big problem that presents with this, I think, is often, should we be doing this all in isolation? Because that tends to be what happens. People are quite insular and they will look to develop their protocols, but there's no information to go out there, or there certainly was at that stage not that much information about this optimization problem out there in the literature. So what can we do? What are other centres doing in response to this challenge? Okay. So that's where this idea came from, about auditing and benchmarking practice in different centres across the UK. It spun out of an IPEM scientific meeting, and we established a working party that was going to investigate this. And the idea was to take long-established concepts we've used for many years in the diagnostic field, the idea of dose reference levels, or diagnostic reference levels, and patient dose audits, and we're going to apply it to the radiotherapy scenario. Okay. So we formed the IPEM Radiotherapy Imaging Dose Working Party, and the aims of this was to undertake this audit of typical imaging doses for a range of common X-ray imaging procedures undertaken in radiotherapy centres across the UK. So it included the planning CT scans, it included the treatment cone beam CT imaging. There were plans to look at 2D and stuff, but we just not had the time. The idea was to publish typical doses for common procedures, put it out there in the literature. People can then benchmark their practice against it, and we can look at the variations that are happening across the UK. Okay, and that could then allow us to adopt some national DRL type quantities. Okay, as well as just making and drawing conclusions from the data we got about what are the best practices that we're seeing out there, what are people doing that work, that perhaps don't work, okay, and sharing that information more widely across the UK. And so the idea was very simple. It's just a bog standard patient dose audit that we always do in diagnostic radiology, where you will collect a sample of many patients, as many as you can get, and their dose indices. So these are dose indexes, they're not effective doses or anything like that. They're metrics that are usually presented on a scanner that you can then use to benchmark what performance. Okay, so we'll collect those for a wide range of very specific clinical indications alongside protocol information, and we'll determine the median from each system. Okay, for each clinical indication, to allow us to compare between different systems, different centres. We can pop those into a distribution of the national doses, and we can use, again, standard sort of practices, which is usually third quartile of that bigger distribution of median doses to determine a national reference dose. Okay? And you can also use the idea of the middle of that distribution, the median of the medians can be what sometimes called an achievable dose, okay, to help guide that optimization problem. But the idea is you look locally at your practice, what's your typical dose, and then you can compare that with what's happening on the bigger picture across the whole country, okay, the national reference doses. So the first one we did was the easy one, CT panel scans, because at the end of the day, it is just a CT scanner. We do CT scans all the time in diagnostic radiology. Okay. So we collected data through 2017. We determined 7 key clinical sites that we were going to look at that were specifically brain, head and neck, breast, lung 3D, lung 4D, prostate and gynae type of planning scans. And we got a fantastic response from across the UK. There was clearly a desire for this to be done because when you do these sort of national audits, response rates tend to be quite low. But here we were capturing sort of 70 to 80% of all centres in the UK submitted data to this audit. And we captured the full range of scanners that we see within the UK community. And one thing that we noticed, and it was already being alluded to in Jenia's talk, was the doses that we used for not only the same type of clinical indication were quite variable between centres when it came to CT planning scans. Okay, we see variations of up to a factor of 18 between the lowest dose and the highest dose in different centres. Okay, a breast was an example that did show quite a significant variation, as shown here. You can see even within that middle 50% of the distribution, we've got more than a factor of 2 variation in doses for just doing a breast planning CT scan. So we did the analysis, we published the values. So these are what have been adopted as UK national dose reference levels for those 7 clinical sites. Bear in mind, it's very specifically related to a particular phantom size when you're talking about CTDI, so that was clearly listed on these values. So heads and brains, we converted to a 16 centimetre phantom because there is a mixture of practice where some centres, their dosimetry values displayed on a scanner might be in a 16 or a 32, depending on how they set their protocol up. But we've got national dose reference levels for CTDI, DLP, and we threw in scan length as well as useful information, because we did see significant variations in how long people scanned in the same clinical indication. Also, if you're scanning longer, you're potentially giving more dose than you really need to as well. We also published achievable values, so the middle of that national distribution as well. So that's the CT side of it. We put that data out there. I'll come back to what's happened since with that. So we then moved on to the cone beam CT scans, and this is where things start to get a little bit trickier. Because we had to consider the fact that manufacturer defaults are predominant, or were the dominant type of protocol used out there. So people just use pelvis for every size of prostate, gynae, rectum, etc., etc. Okay? But we also knew people had done some things to what I'd done locally with my centre, where they'd introduced these size-specific protocols. So we needed to work out how we can bring all that data together. We're also aware of there is this issue, as Colin alluded to earlier as well, about a lack of dose display on some imaging systems, like cone CT. Okay, some more recent models do display a IEC-defined CTDI value based on the wide beam dosimetry technique, and that value will change as you adjust the KB, the MO, and things like that, just like what CT scanner that we used to be applying CT scans. We're also aware that a lot of systems don't have that, so they might have no dose display. Some systems just have a nominal number that's typed in against a protocol, and so if you start changing parameters, nothing happens to the dose value that's displayed because it's just a value that's typed in. There's no necessary standardization of how those values are defined, so we had to work around that, okay, which is not ideal, but it's the problem we face. So we collected data through 2019, 2020, and we asked for 3 key pieces of information. The first was protocol data on all the clinical nodes that centers used. So the KVs, the trajectories, the filters they used, all those sort of parameters. We asked for a patient sample where that was applicable. So if people varied from that default protocol, or they had a range of protocols available, we asked for a sample of patients so that we could analyze the data to work out what was the normal, most frequent protocol we use, the standard patient protocol. And then we asked for some dosimetry information. And as Colin mentioned earlier, we used the CBDI count concept. Idea being, it was simple to measure for most centers compared with the whole wide beam dosimetry technique, which could have introduced errors, and it could have discouraged people from providing us with measurements. So we want something simple, but not too simple. So, we didn't want to just do a dose measured in air, because that would lose the information that's provided by the beam spectrum, can be the filter selection and how that interacts inside something patient-like. So not all centers were able to provide all information, but we did, again, get a really good response. And we had 55 data submissions for variable NOx and 23 for the NECT and NOx. And the basic idea of the analysis that followed was We collected and compared dosimetry information that was provided for all systems. Okay, and from that, we were able to create a normalized CBDI value, so milligrams per MAS, for an average system. So an average varying TrueBeam, an average varying Clinac, an average Elector, Synergy, or what they're called. Okay. We could then use those typical values and assign a weighted CBDI value to each of the protocols that every centre supplied us. So we could say the typical dose for that protocol is this number, okay? And then we can start to compare the different protocols that centres have got set up in their units. And then when variations were allowed between patients, so they have site-specific modes or they change elevation or things like that, we then used a sample of patients to determine the median dose index for the standard patient each centre for each individual clinical indication. Okay? So that last step is essentially what we did in the CT audit. All the steps above are us just covering over the cracks because we can't just go to a scanner, take a sample of patients off and just write down the associated dose values against indices. Okay? We've had to go this roundabout way of doing some measurements, assigning protocol doses and so on and so forth. So we collected normalized CBD values. These are typical values that we collected for body type modes, very common use in all the different centres. We got good sample sizes. It was reassuring that they were nice and consistent when these values were measured in all the different centres. And these are subsequently being compared with some of the ICR peak type missions and found to be very similar to those values across the world as well. We could then assign our doses to the protocols that were submitted by different centres. And what was interesting was when we started to see those centres that had set up with these size-based modes rather than the one-size-fits-all default from the manufacturer, okay, and looking at the strategies that people had applied. So usually a small, medium, large, extra large type protocol was available. Okay. Going hand in hand with that, what we learned, and this was a key learning point from this data, was that if people had gone to the length of setting up these different size-based modes, the key thing that they then had to do was set up a method for selecting those appropriately. Okay, those that set up things like they measured the size of the patient in an image, they looked at the planning CT exposure factors, which are based on automatic exposure control, the use of water with a diameter, all these kind of things. If it was a proactive method, it was an effective way of making sure you've got your small patients using the small protocol, your large patients using the large protocol. Those centres that hadn't set that up and just said, oh, well, we'll just do it by line. If we need to change it, we'll change it. That didn't tend to work so well because they just tended to stick to whatever they started their patients on. Okay. So we're able to do the analysis much the same as what we've done from the CT scanner audit by the end. And there's lots of interesting stuff that we've learned from this. First things we learned is elective centres tend to be very variable and they tend to deviate from the default protocol that the vendor provides to them, okay? But they still tend to use one protocol for all patients. Most variant centres tended to use default protocol for every patient, but those that use this size-based strategy for various systems, what we saw there was that on their average patient, they tend to realise a dose reduction overall of about 30%, okay, compared with the default setting that was used. And that makes sense, because if they're going to provide you a default, they're going to work on most patients. So it needs to work on those big patients as well as the really small ones. Okay? Well, the advantage there with the size-based modes, what we saw was where they needed to in those centres, if they needed to escalate the dose for the big patient, they could. They had the facilities there to do it and they had the method to do it. If they could drop it for a small patient, they could drop it. Right? And so there's lots of useful information in comparing between different clinical indications that we're able to do. The other thing we realised as well was how other things that you don't actually think about come into play, like the scan length. Okay, so here we've got the same as before the prostate and the guide, where the typical doses were similar on these dose indices. But what we observed was on elective systems, where you physically clip in a filter, you have to make a decision on what collimator you're going to clip on that day. For prostate type patients, elective users tend to scan short. Okay, and then when those elective users had a guided patient with longer treatment volumes, they tended to use the longest collimator, because that's the imaging information they needed. What we saw for varying users is they tended to just use the default maximum scan length on all patients. So there's scope for some optimization to be done there as well, and need to be thought about how you select those scan lengths, and maybe some more work for volume users to do about trimming where they feel they can do. So we've gone through the same process. We've published some proposed national dose reference levels. The paper is out there, so there are links available in the talks that people get to follow up afterwards if you're interested. Okay. But the other interesting thing that's happened since all this work started is in the UK, these did get formally adopted as national dose reference levels. Okay. Now, in the early days, there was a lot of debate because traditionally we talk about diagnostic reference levels. And so there was this specific thing changed where on the UK website, these things are identified as dose reference levels. People often get upset about the term diagnostic. Okay? So these are published. These had some weight, but they weren't necessarily legally enforceable at that stage. However, in the 1st of October 2024, there was a change in UK regulations based on the EU Basic Safety Standard. But they've tweaked it now to actually insert dose reference levels alongside diagnostic reference levels as something that we've got to establish, and specifically for radiotherapeutic practices for typical localization and verification exposures. Okay? So it's all in there in UK regulations now that we can't just ignore these things. We have to do and think about these ideas of dose reference levels and doing our dose audits on radiotherapy imaging exposures now. So there's some tips and tricks. I won't go through all of these, but the key things to think about if you are starting out this process of doing dose audits is make sure you get good quality data. Use automated systems where they're available. You've got lots of data collection systems in radiotherapy. Can you use those to automate the process and the analysis? Clearly define your clinical indications. Be specific. Don't just call it pelvis. Call it prostate, gynae, rectum, whatever the specific requirements are for your imaging. Okay. Validate your dosing season. Again, there's a link there to something with some further thoughts. Right. Locally in my centre, we've implemented this. We do annual dose audits for our systems. We produce reports, we produce recommendations, and we've used all those key warnings, automated systems and things like that to make it as slick as possible. We've got local diagnostic dose reference levels. We look at trending all the time and things like that. So back to the whole ICRP task group 116. It's a key recommendation in there is to adopt this concept of DRLs and patient dose audits for imaging radiotherapy. Okay, so we're giving it this term dose reference level with a subscript RT to differentiate it from the diagnostic reference levels that are used for imaging. There's also been some work undertaken through the Mentee group around validating an alternative technique for defining that CBDL, because one of the things we are aware of on an international audience is the availability of the relevant kit, the 100mm chamber, the CTBI phantom. So there's a paper that's just been published that looks at alternative methods using armor chambers, stacks of solid water, perspex, things like that. Okay. So please have a look at that if you're interested. And work is ongoing to try and do some sort of audit in a similar vein to what we've done in the UK, looking at typical doses. So just to summarise, patient dose audits, dose reference levels are a really useful guide to help start optimisation in radiotherapy imaging. They allow that benchmarking against practice in other centres, but remember they are just one tool in the optimisation toolbox. They are not telling you you are optimised, okay? You need to use this information, interpret, learn as much as you possibly can, look at your scan length and all these other bits of information that's telling you when you start digging deeper in there. Okay? They're based on dose indices. They're not patient dose. Okay, further work is needed, as discussed by Jenia, if you want to turn these kind of things into a patient dose. But you also need to think about the other things that go on. So review your image quality. It's not just about turning the dose down. You need to be monitoring how good your image quality is, and that's a good audit to do as well, image quality audits. I also recommend doing things like reject type audits, you know, where you're doing repeat imaging, that kind of thing. What's the reason? What can you learn from that? What can you do to improve your imaging in your centre? Quality data collection is key. So like I say, it's about prostate and gynae, it's not about pelvis audits. And it's most useful when you start to deviate, when you start to optimize your practice locally, because you're not going to be that one value on a graph anymore. Okay, you're going to have a distribution of doses through all your different patients, and you need to monitor how your performance is over time. So that's me done. So I'll hand it back to Colin.
So that gives you some idea of what you need to do to collect the dose information, but then got to think about optimization. So Sebastien Gros from Loyola University Medical Center, he's a physicist who's been carrying out some optimization studies, also looking at image quality. And so I'll pass on to Sebastien to say something about this optimization process.
Thank you, Colin. Can you see my screen?
Yes.
Okay, great. So yeah, I'm going to talk about the work we have been doing at my clinic to try to start some optimization for imaging dose management. And I was really motivated by being a mentee and part of the task group TG116. So it's a quick outline, talk about the background, describe the optimization method that we use at Loyola with a couple of example clinical cases of patients imaged with optimized protocols and a few concluding remarks. So in terms of background, it all started from the 2020 survey that TG116 took on imaging practices that Colin mentioned during his introduction. And basically focusing at the US, where we had results from 30 centers, we clearly saw that KV cone-beam CT was used by 100% of the centers, and that it had become the main modality for radiotherapy. And Jenia mentioned that we know from Jenia's talk that cone-beam CT deliver more dose compared to 2D KV, so it was natural for us to try to focus on optimizing our KV cone-beam CT protocols. Another results from the survey was that basically for 6 treatment regions, the radiotherapy centers were asked to list all the options that they would employ for imaging curative treatment. And in the US, practically 90% of the center performed imaging at least once or more per fraction. So the frequency was at least daily for most of the sites, except from breast. And the last thing I wanted to mention, when you look at whether centers were reporting optimizing or adapting their protocols, you could see that less than half of the center would adapt the imaging protocols to individual patients, and that the protocol optimization efforts were only concentrated in academic centers. And in the US, they are a minority. The majority of the center are community hospitals or standalone centers. And finally, the main point that we got from that US response is that IGRT optimization by therapy medical physicists was prevented by the lack of experience and training in imaging, time, and resources. Basically, diagnostic equipment was not standard in radiotherapy centers, so we were not able to do that optimization work like they do in diagnostic imaging. So looking at imaging, community imaging dose measurement and proposed method for optimization, we have the CTDI formalism, which is applicable to a narrow beam with a chamber long enough to measure the full beam, primary plus scatter, in a 100 millimeter long pencil chamber. We have the CTDI phantom with a pediatric phantom, which is 16 centimeter diameter, and the adult phantom, 32 centimeter, which are used for specific site protocols. And then we have methods that are proposed for wide beam, like cone beam CT, which is the CBDI that Colin and Tim talked about. There's also the IEA method, which corresponds to a central measurement based on a pencil chamber, but it requires in-phantom and several in-air measurements. So for therapy physicists that solo in a clinic that doesn't have a lot of time, it's preventing them to even try to do this. There's also the method that was proposed by APM task group 111 that uses a pharma chamber, but requires now several CTDI phantoms that are stacked together to recover the loss of scatter, basically. The paper that I highlight below is a great reference that's from a group in Australia and provides a good description and comparison of the 3 methods. So in terms of TG116 recommendations, we want to use CBDI for the moment. That was the basis for the study that Tim presented. And it's also the method that we've been working on as part of TG116 with a group of mentees. And Tim mentioned the paper that was just published. You can also have short description of the method in the Annex B of the report. But here's the problem. CBDI requires CTDI equipment, and again, it's not available in the majority of radiotherapy centers. And also the source output verification in the US are performed by typically contracted diagnostic physicists on an annual basis. So we don't have the means to do these measurements whenever we want. Another thing, the ICRP report will be published in 1 to 2 years, and hospital and RT centers have tightened their budget. So if you want to get our hands on that equipment, we probably ask and we get no. So what can we do now as medical therapy physicists to optimize our Cron beam protocols, looking at the equipment we have in our radiotherapy center? So that's what we tried to do. So basically, the first thing we did to an equipment inventory, see what we have, perform some dosimetry on our Cron beam CT protocols, and look at protocol optimization with imaging quality in mind, looking at quantitative assessment and qualitative assessment. So we look at that in more detail. So in terms of equipment inventory, at the time we had 4 Linacs, 4 TrueBeam Linacs, 1 EX, and we were using the default variant Cron beam CT protocol. As Colin mentioned, those are the protocols that are provided by the manufacturer. They provide really good image quality, but are not optimized in terms of dose. So the question I wanted to answer is that can we optimize those by keeping a good image quality? So I looked around in our physics room and looked at the equipment we had. We had various ionization chambers, electrometers, solid plastic water. I found some anthropomorphic phantoms and tried to find things to kind of devise a setup. If you're familiar with MacGyver, you just find what you have and try to design something to help you solve your problem. So basically, we focused on our newest TrueBeam Linacs, which was equipped with the XI system version 2.7. If you're not familiar, the system has a titanium filter and half and full fan filters. The reconstruction of the Cron beam 3D images is with the FDK algorithm. And what we could do is adjust the number of frames that are required for the reconstructions and also lower the exposure per frame. So what you can see in the table is basically the default protocols that we have. We have the head protocol, thorax protocol, pelvis, large pelvis, and spotlight with the different tube potentials. And these are the exposure from the default protocols. So here are the measured CBDI values that we measured with CTDI equipment. And that was part of the MANTI dosimetry project. So I borrowed my diagnostic colleague, physicist, and his equipment to measure these for the MANTI project. And we also put an pharma chamber isocenter to measure air camera. These are the values here. So now, what did we do to optimize the protocols? So we went to service mode and we took the default protocols as baseline and we reduced the exposure or the dose with 2 methods, reducing the number of frames used by the reconstruction algorithm by 27, around 25, 50, and about 20%. Or we reduced the single frame exposure, again, trying to mimic the 25, 50, and we could do it between 66 and 75%. And a combination of both. And we did the optimization by focusing on dose, by lowering the exposure, and looking at image quality. So looking a bit more detail in the Cron beam dosimetry. So again, we measured the CBDI and weighted CBDI in the CBDI phantom. So that's the setup you can see on the top left corner. And we established correspondence with air camera and measured that isocenter with a 0.60 pharma chamber. So this is an example picture of the setup. So to do that, you need some prerequisites. First, you need to estimate the beam quality of the imaging beams. We measured the high value layer with a ray-safe detector. And then we sent the chamber for calibration at an accredited lab. And we obtained our air camera calibration coefficient. And we interpolated our calibration coefficient value for the quality of our beam, which is measured in millimeter of aluminum. Looking at the quantitative assessment of the image quality. So we wanted to design a practical method that could be implementable readily in any clinic. So we based it on our monthly QA procedure, which follows the recommendation of APM report from Task Group 142. And every LINAC is basically delivered with a CAT fan. So that new LINAC had a CAT fan 604, which has several modules, which I'm going to describe here below. And we did perform an automated analysis of the imaging with an in-house application based on PyLINAC Python library. So if you're not familiar, I recommend you to look at it. It's Python based, and you have a lot of different functions to analyze your images. So we saved the results text file and PDF report, and we did an automated analysis with MATLAB. And the image quality was evaluated for the decreased output against the default protocol values. So here, example of some of the modules from the CAT fan. Here we have the high resolution gauge with line pairs going from 1 to 15 line pairs per centimeter. Here, this is the module with different region of interest of different contrast levels. For quality assurance, we use the 1% contrast level for KV cone beam. So here's an example here. The module C actually allows us to do several measurements. The first one is Hounsfield unit sensitometry module. We have 10 targets ranging from minus 1,000 Hounsfield units here for air, going up to plus 1,000, which is Teflon. And in between, you have different material, for example, PMP, low-density polyethylene, polyestyrene, acrylic, and then mimicking bone with 20% and 50% density and so on. We also have a 23-degree ramps, 423-degree ramps, and 3 millimeter diameter hole spaced by 5 centimeter to look at spatial spatial integrity of the system. And the last one is a module that allows us to look at the uniformity and by comparing the Hounsfield unit in different parts of the image at 4 peripheral ROIs versus the central one. So the quantitative metrics we use were the Hounsfield unit constancy and uniformity, and it's against baseline typically when we do QA, but for this work of optimization, we use the default protocol Hounsfield unit values for the different material as baseline, and we had a tolerance of plus minus 40 HU. And uniformity, again, looking at uniformity module. For the low contrast, we looked at the visibility, which is calculated by PyLINAC, and it's a really nice matrix because it combines the contrast with the ROI size and the noise. And it mimics the ability of the human eye to detect signal against noise. So it's a component of low contrast visibility. So for example, like the Las Vegas Phantom for MV or that CAT fan module, large size object with small contrast might be seen, but small objects with the same contrast might not. So that allows us to look at that. Then looking at the high contrast resolution, we can compare the relative modulation transfer function curves or look at values like the M50 that corresponds to the effective system resolution or the MTF10, which corresponds to the limits of our imaging system. And for our QA, we actually just do a visual detection of line pair separations. And then spatial integrity, I mentioned the pore holes and the 23 degrees warm. For quantitative image quality metrics, these are the phantom I found in our cabinet. We have a Steve head phantom, a thorax phantom, and a pelvic phantom. So results from the dosimetry, we evaluated 43 protocols from those defaults, and we designed custom design a pediatric protocol for pediatric patients, and we evaluated 9. So basically, what we saw from that, we established a linear relationship between exposure, CBDI, indices, and air karma that allows us to establish the relationship between CBDI and air karma. And that was very useful because it was difficult for me to access the CDI phantom and also the time constraint to perform those CBDI measurements. You just stick the pharma chamber at isocenter, you do your measurement, and then you're done. So this also useful for the comparison of imaging dose between our 4 different LINACs or with an external institution equipped with different imaging system with or without no calibration or CBDI to determine, to compare our doses. So these are the coefficients that we established from that. Looking at the low contrast visibility, here we have the exposure on the X, on the Y we have the low contrast visibility that is described here, and each color corresponds to a different protocols. I indicated the two potentials. So here we have the head protocol going up to the thorax, light blue the spotlight. Here we have the pelvis, and in yellow we have the large pelvis. So one thing that we see that the low contrast visibility decreases with exposure and beam quality, and the head, spotlight, and thorax will be most affected by reduction in exposure dose due to the high correlation and high sensitivity to exposure. So what does it look like on the phantom? So here I'm showing the example for the head protocol. At the top left, we have the default protocol, 500 projection, 150 MAS. This is our CTDI value. And if you follow the arrows, you lower the projections to 367, that's about 25 reduction, 50% reduction, and about 75% reduction. And the main observation that you see is that you can barely see the contrast targets here, and you increase the noise, basically, when you lower the dose. Okay. Now, looking at this one is the large pelvis protocol. So we have a higher tube potential, 900 projection going down to 180 projections. And you can see what happens when you lower the dose. You can still see some of the targets, but when you get to very low dose, you start to have some artifacts from the reconstruction. Looking at the Huntsville unit linearity and conformity, those are a bit complex graph, but you have the different in issue between the default protocols and optimized protocols. And here you have the exposure on the x-axis. And what you can see that for the head, spotlight, thorax, and pelvis, most of the targets stay within the plus minus 40 Huntsville unit difference. Only for the large pelvis is when we start to see going outside of the tolerance. But when we looked at the images, we could not see any visible difference. So that might not be an issue for the large pelvis protocols. Now, looking at the high contrast resolution, we can see there's pretty much no correlation between the high contrast resolution and reduction in exposure. Again, we have the light per millimeter, the relative reduction to upper functions, and here the different levels of exposure, and the curves are pretty much on top of each other. And when you look at the phantom, same thing, you're going from 500 projections, decreasing 150 MAS, decreasing now the single frame exposure, and you can see pretty much no changes in your line pairs per millimeter. What we see, though, is an increase in the noise in the background. Looking at the spatial integrity metrics were unaffected by the change in protocol parameters, which is nice. We know that our convexity will look the same, whether in terms of dimension, whether we have the default or those protocols. A quick flash on the statistical analysis, looking at correlation coefficients. Basically, the visibility and uniformity had stronger moderate correlations, whereas spatial integrity and high contrast had no change with decreasing dose. Looking at the qualitative image assessment, this is the head protocols with the head phantom. Here we're decreasing the number of frames at the top. Here we're keeping the number of frames constant and decreasing the single frame exposure. And what you see that when you decrease the number of frames, you start to hit a point when you start to have reconstruction or aliasing artifacts. So that might affect your visibility when you use these images clinically. Just reducing single frame exposure, we just increase the noise where we don't have those artifacts popping up. Now, same exercise with the thorax and lung phantom. Here we're focusing, you can see that again, for a low number of frames, you start to have those streaks from the aliasing artifacts. If you keep the number of frames constant, then you end up with just higher amount of noise. And this is for the large pelvis. Again, for a low number of frames, you can see those artifacts that might affect your ability to align the patient. So based on this, we looked at all the 40 plus protocols, and with the goals of maintaining a clinically appropriate image quality, lowering the dose and immediate artifacts. And we established that we could lower the imaging dose by 80 to 50% and retain a clinically acceptable image quality with minimal interference from those artifacts and the noise. And this is for each of the protocols we had for the head, 70% of the default dose, thorax 57%, pelvis 52%, large pelvis 51%, and spotlight 76%. So what does it look like on real patients? So this is the first example of pelvis patient where we switched right in the during this patient's treatment. So here you have patient coming CT with the default protocols. Here I have highlighted the PTVs that our therapists used to align. And this is the pelvis low dose with a 48% reduction. So our therapists were interested in being able to see the rectum and the nodes, and they were happy with the image quality. If they're happy, I'm happy. Otherwise, we have to go back to higher dose protocol. The next case, that's a female patient with a large pelvis protocol. And here the therapists were interested in looking at the bladder and urinary nodes. And this is the default protocol. This is the low dose with 50% dose reductions. And again, our users, the therapists, were happy with that. So we kept using that protocol for the patient. This is the head and neck case. So now it's a bit different. We have the CT SIM and head and neck. Sometimes in the neck, you want to align based on some nodes. And this is an example of a node in the neck. This is from the CT SIM. This is from the head low dose community protocol with about 22% reduction. And we can clearly see the nodes here on the three different planes from the cone beam CT. And finally, we had our CNS physician that requested a custom protocol for a pediatric patient that had several rounds of radiotherapy prior to the next round. And so what I did, I didn't have the CDI phantom, so I just stuck my pharma chamber, used the head phantom, and I investigated lower dose protocol first by changing the kVp from 100 to 80 kVp, measured relative air current with the pharma chamber, and I proposed to her two protocols. One, which had 75% dose reductions, keeping 500 frames, just reducing the single frame exposure. And another one where I reduced the number of frames, just allowing some artifacts. And to my surprise, she picked this one, which was about 88% dose reduction, because she was only interested in the contrast between bones and soft tissue. So here's the example from that patient that had two bilateral mastoid targets. You can see the tumor really nicely with the bone, within the bone, but we had no soft tissue contrast. But for that patient, that was appropriate. So conclusions, that was the first step towards the management of imaging dose by optimizing protocols in a quantified and qualitative manner for our clinic. And imaging protocol optimization for IGRT should consider dose and also image quality and clinical use. Basically, you don't want to lower dose, try a protocol on a patient, and then realize that you have to image the patient again with a higher dose protocol because you cannot see anything. That method is readily implementable in RT centers, even TTDI phantom recruitment or KB calibration of the pharma chamber are unavailable. You can just perform relative measurement with the IO chamber, or you can use the variant provided value data for CBDI. We don't have any data on the applicability of that method to other community-based IGRT system. So if you have time, if you have an Electalinac, RadExact system or other, it would be nice if you could do similar study and publish the result or reach out. And final comments, that optimization, I didn't do it alone. It's a team effort. So you need the physicist with the technical expertise. You need to talk to your users. They are the radiation oncologist or the radiation therapy technologist who are using the images to align the patient. If you can get help from an imaging physicist, please do, if possible. It will save you a lot of time. And in-service training should be implemented because, for example, our radiation therapy technologist did not have experience or training in optimizing and using the different handles you could do to change your combing protocols. You need to understand the requirement for use of IGRT, so that the justification that Big Small talked about. Do you want to do patient alignment, adaptive radiotherapy, looking at the sites, what do you want to focus on, and what type of patient you are working with, and be conservative when you decide to lower your exposure. So use higher dose protocol for the first fraction if you are not sure what you expect. and my acknowledgements. Thank you so much.
Sebastien, that gives you some of the idea that you might have to do when you're sort of optimizing to make sure the image quality remains adequate. Yeah. So we now move on to cover the pediatric, which is probably one of the most difficult and one of the most important areas. So Tomas Merchant from St. Jude's Children's Hospital in Memphis, Tennessee, is an oncologist working on this who will tell us about that.
Thank you. I hope you can hear me. I want to thank Bill Small and Colin Martin for inviting me to participate. X-rays are often the first imaging modality used to evaluate pediatric patients when cancer is suspected. They play a critical role in assessing children with brain tumors, musculoskeletal tumors, and tumors that are almost exclusively diagnosed in pediatric patients. X-ray CT is the preferred imaging method for evaluating the presence or absence of pulmonary metastatic disease in patients that have tumors with a high propensity for metastatic spread. In developed countries, the use of ionizing radiation for diagnostic purposes is generally limited after the initial diagnosis and staging, and this is a key point. However, this is not the case in low and middle income countries where X-rays in their various forms remain the sole diagnostic imaging modality available for pediatric cancer patients. Ionizing radiation therapy is a cornerstone in the treatment of childhood cancer. More than 50% of children diagnosed with cancer in developed countries received radiotherapy as a part of their frontline management, and this statistic persists even with the removal of radiotherapy as a component of CNS-directed therapy for children who are diagnosed with acute lymphoblastic leukemia, which is the most common form of childhood cancer. For children with brain and spinal cord tumors, radiotherapy is essential and often utilized even in patients as young as 12 months of age. In the case of musculoskeletal tumors, the use of high-dose radiation therapy is frequently required for definitive therapy, depending on the extent of surgical resection. And for the soft tissue forms of musculoskeletal tumors, radiotherapy doses may be attenuated based on extent of resection and the tumor's response to systemic therapy. And then finally, for the unique pediatric solid tumors, radiotherapy plays a critical role in treating both residual tumor or patients with subclinical microscopic disease. X-ray modalities play a vital role in treatment planning for children who require radiotherapy, and they're routinely used for localization and verification prior to actual treatment, similar to adults. Although most pediatric tumors are best seen and delineated using multi-sequence MR imaging, CT is required for the accurate assessment of tissue composition, and it serves as a coordinate system to which other imaging modalities are registered and the basis for comparing in-room localization and verification. For pediatric patients, this has evolved to include daily cone beam CT methods for most patients. The use of image guidance in pediatric radiotherapy has been studied by different pediatric cooperative groups, mainly in North America and Europe. And according to investigators from the SIOP Europe, CBCT is extensively utilized for pediatric patients undergoing radiotherapy, particularly in the context of image-guided radiation therapy. According to their survey, cone beam CT is used daily for treatment verification in most cases, with 84% of centers employing it as a standard imaging modality for brain and head and neck sites, and 70% for abdominal sites. Despite its widespread use, key challenges include concerns over radiation exposure and the lack of optimized pediatric-specific protocols, and this hinders consistent application across institutions. There's considerable variability in cone beam CT protocols used for pediatric IGRT, for brain and head and neck sites, showing the most consistency compared to abdominal sites, and this underscores the urgent need for standardization and optimized protocols tailored to children. And although low-dose cone beam CT protocols are feasible and well supported by research, they remain underutilized in clinical practice. This is a missed opportunity for reducing radiation exposure to pediatric patients who are more sensitive to the effects of imaging doses. And notably, only 39% of surveyed facilities reported optimized exposure settings for pediatric patients. Investigators in North America, representing the Children's Oncology Group, found that cone beam CT is widely used for pediatric patients undergoing radiotherapy, especially for those methods that require high precision, such as intensity modulated radiation therapy, volumetric arc therapy, and proton therapy. CBCT plays a crucial role in complex treatments, providing enhanced soft tissue visualization and ensuring patient localization. And while it's invaluable for improving treatment accuracy, there are concerns about radiation dose exposure in pediatric patients, and this has prompted efforts to minimize radiation doses. These efforts include implementing lower dose protocols, exploring alternative approaches, and using non-ionizing imaging methods to ensure both effective treatment and long-term safety. IGRT plays a vital role in pediatric radiotherapy by improving treatment accuracy. It also ensures precise tumor localization while minimizing safety margins. Its application in children requires tailored protocols to balance treatment efficacy with long-term safety considerations. When it comes to imaging frequency, daily imaging is a standard for pediatric radiotherapy. Kilovoltage planar imaging is typically preferred for much simpler treatments. And while cone beam CT is used for more complex cases, non-ionizing methods such as surface imaging and MR guidance are also encouraged whenever feasible. In the publication, we highlighted the use of ionizing radiation therapy-based methods for evaluation and treatment of selected pediatric cancer patients to increase the awareness of utilization and exposures that might affect childhood cancer survivors. Neuroblastoma is the most common pediatric tumor. It often requires conformal methods to minimize dose to vertebral bodies and organs such as kidneys. Advanced imaging verification is critical because of the smaller clinical target volume margins used with more advanced methods. Radiation therapy for neuroblastoma typically occurs late in the treatment regimen following high-dose chemotherapy consolidation, and this timing reduces the likelihood of anatomic shifts in healthy tissues or responding tumors and might allow us to reduce the imaging frequency. On the other hand, rhabdomyosarcoma, the most common pediatric musculoskeletal tumor, requires frequent imaging due to the changes in patient anatomy and tumor response during therapy. And these changes can necessitate replanning and additional treatment planning CTs, especially when using highly conformal radiation methods with small margins. Two additional tumors, ependymoma, it's the most common localized brain tumor in children, and it's treated with very high doses of radiation therapy, and often in patients even as young as 12 months of age. It's typically located near critical neurovascular structures, and the small target volume margins used necessitate daily verification imaging to accurately target and minimize adverse effects. And while secondary cancers are rare in these patients, there is ongoing concern about the contribution of repeated diagnostic quality X-ray during treatment. And then finally, medulloblastoma. It's the most common malignant brain tumor in children, and treatment involves craniospinal irradiation, which is a very large volume of treatment. And this treatment exposes substantial volumes of healthy tissue to radiation. It makes imaging during treatment essential for precision treatment, particularly when we use advanced methods like intensity modulated radiation therapy or proton therapy. And then finally, secondary malignancies and conditions like cataract formation are examples of risk linked to collateral radiation exposure. And this also underscores the importance of optimizing radiation imaging protocols and exploring non-ionizing radiation imaging alternatives. In summary, if we consider long-term considerations, radiation oncologists treating pediatric patients must carefully balance effective tumor coverage with minimizing long-term complications, as imaging plays a critical role. For pediatric patients with solid tumors and musculoskeletal tumors, X-ray-based imaging primarily verifies patient positioning, but secondarily, it's used to evaluate external contours, tumor changes, and sometimes internal tissue deformities that may impact dosimetry. And as mentioned by others today, there is insufficient awareness among healthcare providers about the risk of exposing healthy tissues to repeat diagnostic quality X-rays during IGRT, and this is often overlooked in clinical protocols, even at the level of the pediatric cooperative groups. So consent forms and follow-up procedures are required. Despite the benefits of IGRT, concerns about low-dose radiation exposure have led some institutions to favor 3D conformal techniques over the more advanced photon techniques. Greater discussion, the standardization of guidelines is needed. And then finally, optimizing pediatric imaging. Technical advances such as reducing radiation field, iterative reconstruction, adopting non-ionizing imaging methods like MR and optical surface guidance offer promising opportunities to minimize radiation dose exposure to healthy tissues in pediatric patients. Thank you.
Thomas. So we're running a little bit behind time, so we'll quickly move on to Aurelie Isambert from ASNR, the Nuclear Regulatory and Radiation Institute in France, who's going to talk about what can go wrong, some of the way errors can occur and lead to errors in treatment, or imaging can lead to errors in treatment.
Can you see my screen?
Yes. Thanks.
Yes. Okay. Thank you. So good morning, everyone, afternoon or good evening. I'm very pleased to share with you today a summary of the errors resulting from imaging that have been reported worldwide and lessons learned. So, sorry, I'm trying to move on my screen. Yes. Here, okay, sorry. So my talk today corresponds to the current draft report section 11 in Annex C, which title is Avoidance of Errors Originating from Imaging in Radiotherapy. So as we all know, over the last 20 years or so, the field of radiation therapy has seen unprecedented technological developments, which have resulted in the use of more advanced imaging in radiotherapy. We also know that radiation oncology is generally safe, with a low rate of adverse events, leading to clinically significant adverse outcome. But however, some errors can happen while using imaging. But first of all, what do we mean by errors in this report? Indeed, among the various recommendations we have for risk management and reporting systems worldwide, there is little uniformity in the terminology which is used, as it's stressed in a report from the European Commission. In this presentation, the wording errors is used as events that can lead to unintended and accidental medical exposures, as described in the IAEA or Euratom Basic Safety Standards, and also includes near misses, which are incidents which did not reach the patient as defined by the WHO. So worldwide, we have available several incident learning systems, or we also have national radiation protection authorities, which published regularly reports regarding the events which are reported to the authority or newsletters. So in my next slides, the most of the examples I will show are extracted from these sources. I put here the logos of the main sources I've used. For instance, the Rose Incident Learning System from the US, sponsored by ASTRO and the AAPM, the Saffron System from the IAEA, and also I've used newsletters and reports published by national authorities, like in Belgium by FUNC, or Australia, ARPANSA, STUC in Finland, or ASNR in France. So in these errors, which are reported and available in these different sources, these errors are described while using imaging, are described mainly at 2 steps during the treatment plan preparation and the treatment delivery. For the first step, treatment plan delivery, here again, we can more or less sort the errors into 4 subcategories. First one being the incorrect target volume delineation. The second one, the use of a wrong set of images. The third one, errors from processing of image data. And a fourth one, differences in patient positioning between imaging and treatment. Because I have only 10 minutes today, I will focus only on the 2 first one, incorrect target volume delineation and use of a wrong set of images. So for the first one, incorrect target volume delineation, in the reports available in the different websites I showed you before, the contributing factors which have been identified are when there is a doubt about the location of the lesion to be treated, and so when there is an uncertainty about the side of the body, which had the consequence with the laterality errors, or when multiple lesions are present, such as an additional benign target or a target that has been treated previously. In these reports, there are some preventing actions that are proposed and which could be useful to be considered. Here I put only 2 of them. The first one being conducting a prospective peer review before initiating the treatment plays a crucial role, which is even more crucial and qualified as vital in some reports in the case of high-dose and hypofractionated treatments. A second preventing action, which is provided in some reports, is the role of radiographers, which is raised. The role of radiographers and also the involvement of patients when it's possible to perform a check about the laterality of the treatment of the site to be treated, to check the injury and the scar control when it's possible, mainly in the case of breast treatment. Second subcategory during the plan preparation is the use of a wrong set of images. This can be of 2 kinds: the use of images from the wrong patient, or the use of the images of the proper patient, but with using the images of a previous treatment. In the case of successive treatments, outdated CT can be used for planning and be the source of errors. So again, on the reports available online, there are some preventive actions that are proposed and useful to be considered. For instance, to identify planning cities with scan names that are unambiguous, to put scan dates in the scan name, and also, when possible, to consider discussing with the manufacturer to see if there is something which could be done to improve the software to avoid this kind of error. Now, the second step during the treatment delivery. Here again, in the different reports available online, there are 2 subcategories mainly of errors which are described: the incorrect vertebral body localization and differences in motion management techniques. Again, because of the time, I will focus only on the first one today, the incorrect vertebral body localization. And I focus on this one because it is the one which is the most described actually in the reports for the use of imaging in radiation therapy. In a newsletter from France some years ago, it has been described as one of the main causes of significant events in radiotherapy. And also this conclusion has been given by the Australian authority, ARPONSA, regarding this kind of errors. And it has also been described many, many times in other ILS in the US, in the Royals, and by the authorities from Belgium or Finland. So that is a very common errors which is faced while using imaging in radiotherapy. So for this kind of errors, again, there are some preventive actions that are described in the reports. For instance, increase the length of the field of view to include either the superior or inferior portion of the section of spine being treated. To use matching of the multiple anatomic points, to include dose control, to set maximum tolerances on the shifts allowed between setup and treatment, and where available, to use optical surface guidance that can offer an independent check on the patient positioning. Before concluding, I would like to highlight two papers which have been published quite recently last year, one from Australia and one from the US. The first one in Australia is a paper published by a radiotherapy team that has identified that verification imaging is the second source of incident reports in the ILS. Another work performed by a team in California. They have performed a retrospective analysis of more than 17,000 registrations between planning CT scans and pre-treatment CBCT scans. And through this analysis, they have, of course, highlighted the reliability and safety of IGRT. But they, through the errors they have detected with this retrospective analysis, they stressed that the incidents that occurred expose safety gaps still present within the patient alignment process. So at the conclusion, we all agree on the fact that imaging in radiotherapy has led to major advances in the quality and safety of treatments. Incidents and errors are an important opportunity to learn and improve processes, and this also applies to imaging in radiotherapy. Thank you for your attention.
Thank you, Aurelie. Hopefully, people will carry out the appropriate checks when using imaging, so this won't increase the numbers of errors. So we're going to finish off with a talk by Tomas Kron from the Peter MacCallum Cancer Centre in Australia, who's going to talk about something about the impact of the recommendations might have on practices. Thomas.
Thank you very much, Colin, and good evening, good morning, wherever you are. I hope you can hear me, and I'd like to finish off this session by talking about the impact of the recommendations. I do this really as a medical physics old hand, but an ICRP novice. And that is quite important because that means I can sit out in the community and really look at the ICRP and see how can that impact, how can that affect our clinical practice in radiotherapy. And by doing that, I first sort of thought, what makes ICRP generate impact? Why are these reports so important and impactful for us? Well, for me, as a radiation oncology physicist, they are based on quality data, and the TG116 report also includes more than 400 references. The topics are relevant. They certainly are relevant for me as a radiotherapy physicist, and the contents is applicable internationally. But the group has taken great care to try and cover image guidance and imaging in radiotherapy, really not just from a high-income country perspective, but really from a low to middle and high-income country perspective. And that yields then some generally pragmatic approaches which find their way then into the recommendations. This is my home institution, and I just want to use that opportunity to declare a potential conflict of interest as we have research collaborations with a number of niche guidance systems groups. We have already talked about the imaging in external beam radiotherapy, and we've seen that in the patient pathway, as you can see it here. Imaging is clustered in the treatment planning area, here with motion management, imaging for planning, and so on. And then again, in the treatment delivery area, where you can see that the patient precision verification is an important aspect of the imaging. You can also see here in this small vignette in the lower left corner that the imaging dose on the right is really distributed very, very differently than the therapy dose. As such, we are needing to add or to consider two different dose distributions. It is also relevant to highlight the fact that modern radiotherapy equipment is virtually only defined by its imaging modalities. The linear accelerators, which deliver X-rays between 4 and 18 or 20 MeV X-ray energy, they are always virtually identical. What distinguishes linear accelerators and therapy equipment is really all the imaging kit which is there. So if one looks at it, the impact of a report, that would mean that we do need to somehow also do some horizon scanning, and having the mentees in the group was really, really helpful in terms of bouncing ideas forwards and backwards, because we don't quite know what additional new imaging will be there tomorrow. The impact, though, of the report needs to be seen in the context of concepts rather than specific technologies, and I hope I can illustrate that in the way these their report is aiming to produce impact. It does that by information sharing, education, providing background and motivation for training and actions. And you have sort of participated in that in this webinar in a number of really excellent presentations. But I think it is really the recommendations at the end which sum up all this information and provide recommendations which can have direct impact, hopefully, in clinical practice. They initially are for health professionals, then for equipment vendors and regulators. If one looks at the health professionals involved, there are 17 recommendations for them, which have direct implications in terms of how should we as health professionals, medical physicists, radiation therapists, and radiation oncologists, but also other health professionals, how should we work with imaging equipment? And they are really informed by the classical ways of radiation protection, looking at justification, optimization, looking at what resources are available in a particular an environment, and then alert to something which I think two of the speakers have already said, that there is a real benefit of having diagnostically trained medical physicists available, at least in a consulting role when setting up imaging protocols in radiation oncology. And then there are the dose records, and the idea is really that we all felt that inclusion of doses from MV imaging really must be explicitly included in treatment plans. For KV imaging, that's still a bit further off, and it requires Monte Carlo calculations, but it is something manufacturers should really consider as something to be implemented. This is particularly relevant, obviously, in the context of pediatric imaging, and Tom Merchant has already given you some background of that. QA programs are required, and then training and education. So as such, this is a fairly standard procedure in terms of the recommendations. It gets a bit more interesting if one actually looks at how these recommendations then impact clinical practice or practice overall. And I've tried to illustrate that here in the context of ICRP publication 103, basically the recommendations from 2007. And they make their way into Australian clinical practice really via international safety standards, by national guidelines, codes of practice, and so on. And finally, in these circumstances, about 10 to 15 years later, make their way into regulations and into legally binding acts. Now, to try and fast track that process, the recommendations also include recommendations which are directly to equipment vendors and software developers. And they obviously sort of can kickstart, hopefully, this process of effecting change. The vendors should include displays of measurable dose quantities. And I think this is obvious in diagnostic imaging, but it is not general practice in radiation oncology. So all these recommendations have really direct implications, hopefully, for clinical practice as affected and made possible by collaboration with vendors. And certainly vendors we've talked to throughout, they typically are quite interested in what is said there. It just basically means that therapy equipment, or at least the imaging part thereof, should catch up with imaging. And then finally, there are recommendations for regulators and professional bodies, which basically pertain to the fact that the regulators actually have also tools to try and optimize patient care in radiotherapy, patient care in this context, through the use of optimized imaging as such, which could be helped by providing authorization, by providing some certification and accreditation, and by using the same tools and making it compulsory to use the same tools we use in imaging, also in therapy. So in summary, from my perspective as a novice in the ICRP world, I was impressed to see that the report is really written keeping in mind how it can directly help to improve radiological protection of patients. It is also quite clear in the discussions we had that imaging dose is not always low in radiotherapy, and often and always distributed in non-targeted healthy structures, and rarely documented and optimized. So there is some action to be taken from that. And the recommendations aim to be pragmatic, but create tasks not only for practitioners, but also manufacturers, professional organizations, and governments. And we hope that this has then an impact on the radiotherapy practice. And I don't want to tell you who of these gentlemen is Colin Martin, but you can certainly be certain that one of them is. And the hope is really that we will attack at least the wall of RT community's complacency on low doses and RT manufacturers' inertia. Thank you very much, and really happy to answer any questions.
Thank you, Thomas. That's a good summary, and we hope we can take it forward. We sort of have got 5 minutes left of our allocated time, but Thomas and others have been answering all the Q&A as we've gone along. So we haven't got any questions currently in the box. I don't. Does anybody remember any of the ones that might be useful to give a more sort of general comments on? I think if we can put back on our videos and audios, then we can have a maybe a little bit of discussion. I mean, we came to it sort of feeling that not much emphasis was placed on the doses from imaging, and we got certainly had the impression that many people thought that they were so small that we were sort of perhaps being a little over enthusiastic trying to take action. But I think as we've gone along, we've really discovered that there is plenty of scope for further optimization. Thomas?
I I also would like to point out that we are really only at the start of discovering the impact of low doses in the context of patients and in humans overall. As many of you know, the immune system has been now implicated in a lot of the reactions, in a lot of cures and adverse reactions to radiotherapy. The immune system obviously consists of cells which are exquisitely radiation sensitive in terms of the immune system. So it stands to reason that also low doses to large volumes may have some very different biological effects which we need to be cognizant of. Similarly, cardiovascular effects in terms of radiation delivery may have some low dose components, which we are just sort of starting to become aware of. So I think what we are seeing is not just the cancer effect, but potentially also implications of low doses from imaging in other biologically relevant areas.
Bill, do you want to come in?
Yeah, I can't agree more with Thomas. In fact, there's some correlation with outcome with lymphocyte during radiation, and that's exquisitely sensitive. So besides for deterministic and stochastic effects when it comes to secondary problems, it may even be better for the cancer treatment to minimize. I think there's been a basic, and maybe Tom can comment too, in the US, at least in the US, a basic we don't care attitude because it's such a small dose compared to what we're delivering. But I think that is something that we should definitely care about.
Just to add to what Bill said, the importance of image guidance in pediatrics has been demonstrated during the past 30 years, where we've reduced the target volume margin substantially in all pediatric tumors. And this would not have been achievable without imaging in radiotherapy. And this certainly has reduced not only the complications associated with radiation therapy in children, but it's also reduced the incidence of secondary malignancy and other collateral side effects. And so, thank you.
Yeah.
I just wanted to add here on the question regarding the insignificance of doses from imaging compared to radiotherapy. Yes, they might be a small percentage of the therapeutic dose to the tumor, but a large volume of healthy tissues around the tumor are getting hundreds and sometimes maybe thousands of milligrays, as was demonstrated. And this is not insignificant dose, I think, because the colleague who asked the question asked for evidence. There are evidence published in the literature on absorbed dose to tissues surrounding the tumor, in accumulation going up to hundreds, several hundreds of milligrays. And this is already bringing the dose into the moderate risk according to the classification, or even higher risk. So that's, I think, the main argument, also with the long extended life expectancy for cancer patients, and of course for the pediatric patients. This makes the very important the task to optimize imaging doses.
We're starting getting a few questions in now from the floor. Well, one, working as a regulator, what can we say about seeing a facility conducting cone beam CT daily for breast patients? Any recommendation?
I don't know if we have the data on that kind of stuff. It does, if you're doing partial, I think that is it meaning the whole breast? I don't necessarily see the benefit, but it's always hard to know the individual patients and their own mobilization and what they're doing. I don't do that.
we're in consultancy period for recommendations. Would you consider amending the recommendations if the impact analysis of the stakeholder by the consultancy indicates that some are not practical? I think it depends on the particular recommendation that, so I'm not sure exactly which ones that would relate to.
One theme that's been picked up a couple of times in questions is around measuring doses, dose audits, things like that. I think it's just worth emphasising again that, the stuff I presented was the UK approach. It was using readily available equipment in the UK, which is standard CTDI phantom, standard CT chambers. As the ICRP mentee group, we've taken that concept and tried to make it more widely applicable. So using more readily available equipment that may be available in other radiotherapy centres. So if people are concerned around how they do the dose audits and things like that, please do go look to that paper, which presents some alternative methodologies that have been assessed. That, the ideal solution is long-term manufacturers present these values on the console. You just validate it with appropriate equipment when you install your new machine. We're not there yet. The next best is you get the CTDI phantoms, the CT chamber. If you can't do that, we've presented also alternatives that should be achievable in, I would hope, all, or certainly the vast majority of centres across the world in that recent paper. So I don't know if that's what that was partly alluding to about not practical.
And also the ICRP recommendations, they are going to be enforced really, or the recommendations for the next maybe 10 years. So we have to set out sort of things that we're sort of aiming towards. And we've tried also then to develop ways, practical ways in which centres that don't have the equipment at the present time can gradually develop what they're doing and move towards a system where it will be much closer to, say, the things that Tim has described in his presentations. The question here, any investigations on adjusting KV to improve contrast in pediatric imaging on bony structures while reducing MA?
Yes.
Anybody know about that?
Yeah. Yes, I think that certainly is something several people have done. What will be interesting is now newer CT scanners, if they have new tools available like direct density measures, spectral CT, and we may see the field really shift there. But yes, makes eminently sense to do that. When we started out with Conview CT and these units, we actually also used additional filtration in some circumstances and actually taped something on the X-ray tube because the manufacturers didn't really think of that. But it is really important that the community maintains an active interest in that. Otherwise, we end up with black boxes where we can't actually do this investigation, which you really have pointed out is relevant and important.
And here's one possibly for you, Aurelie. In terms of errors reported in radiotherapy, in the UK, we see on-treatment imaging associated errors as the most frequently reported type. A notable proportion of these are attributed to equipment malfunction. Are these being seen elsewhere?
Well, actually, in the reports that I have had chance to read and to have access to, the main errors that I've seen are those that I've described in my talk. But of course, there are some errors which could have the origin from the machine malfunction. But to my knowledge, it's not the majority of them. But Yuna, I will contact you. I've seen your comments, and I will check that with you.
I mean, I could speak from a UK perspective on this, I guess, because I get the job of handling incidents on a regular basis. The typical cause of error that we're seeing that I think Una's picking up is, you'll get an MLC fault on a particular LINAC, it will break down, so they'll have to take the patient off, they'll have to move them to another LINAC, and then they have to be re-imaged, so they're getting repeat imaging. And under our regulations, we have to investigate such cases as that, and then you determine if it's themes, if it's reportable and things like that to the regulators and so on and so forth. And it's just the complexity of modern equipment, it is fairly unique to radiotherapy, but we see other similar sort of scenarios elsewhere.
Yeah, and I agree with you, Tim. Maybe it depends on what has to be reported or not, and what is available or not in the reports and IELS. So maybe it's not the same level of details in all regulations. So maybe this kind of event is not shared everywhere.
And someone asked, will there be monitoring or reporting introduced by both ICRP to monitor the process? I think we'll just see how things develop. I mean, presumably the IAEA will be looking at this, and also, but I don't think the ICRP as such will be following things up. But basic safety standards and other things will hopefully incorporate the things that we proposed. I think we've been through all the questions. Thank you thank you to all the panel and all the speakers, and thank you very much to all the people who've been joining in and asking us questions. And hopefully, we'll be gradually sort of introducing all the things that we've proposed over the next few years. I would imagine that the reports will be out. Well, I think we'll finish our part of the reports probably early next year, and then the ICRP might take another year or so to actually get it into the final form. So I think that's likely to be the timescale, but we'll probably try and write other things up, so there will be information on what we put in the report available through publications. So thank you. And
Thanks, everybody.
Just say goodbye.
Thank you.
Cheers.
Bye, guys.
Bye. Thank you.
Bye, everyone.
Bye, everyone.